Okay, we're on Module 13, page 119 in your book. Here's your need to know words, and we'll go through them as we go along. And this chapter is on restoring restorative care. So I want you to think of restorative care as rehabilitation. So we're going to explain the goals of rehabilitation and restorative care and the use of assistive devices, what benefits of exercise, complications of immobility, not being able to move, and know your describe activities of daily living and describe ROM, which is range of motion exercises. So the goal of this long-term care is to rehabilitate, try to restore what was lost if there was an injury or illness, or assist the client to be as independent as possible. And that's often using assistive devices like walkers. Um, our actions are to encourage the client to do as much as possible. If the more the caregiver does, the more you take away from their client's control and contribute to their decline. Okay, your book doesn't have the rehabilitation team, but some of your clients coming in, if you go to a home or an assisted living, might have been in rehab. Um, and that's why they end up in assisted living and or have you in their home. So I want to tell you what they are. First, there's the physical therapist. They help injured or ill people improve movement, and it's usually big movement, big arm movements, big leg movements, or walking, going upstairs, and also manage the pain because a lot of times it's muscle pain, and they work with that. An occupational therapist has nothing to do with a career. It has to do with your activities of daily living. So if you think of a retired older person, their main job now is to get up, get dressed, eat, take care of themselves. That is their activities that they work with. So they assist clients that have injuries, illnesses, or disabilities perform the activities of daily living, such as bathing, grooming, toileting, eating, showering. And then there's speech therapists. They work with speech problems, but they also work with swallowing problems for someone who's had a stroke, some kind of muscle weakness. Um, So when we think of restorative care, usually a restorative care is a position in skilled nursing, I want you to know, first of all, because that's where it's used mostly. And what it is, let's say a client comes in and they're in rehab, they see physical therapy, occupational therapy. Once they've kind of hit a plateau and they're not progressing anymore, and or their insurance runs out for rehabilitation, then they're put on a restorative team. And that's nursing does those care. And it's just kind of follow up, keep the patient walking, keep the patient doing exercises wherever they were left. So it's trying to keep the client, emphasizes the client, restorative care will emphasize the client's ability to perform tasks as independent as possible. So it might be walking, getting dressed. So we're trying to keep them independent. And so when someone is on restorative care or rehab, either one, the care team would determine what they think is possible that that client could do, make some realistic goals, and try to develop some plan of care that might get them up to that level to promote independence and their highest level of physical, mental, and emotional wellness. Okay, so remember that clients always have rights and they have the right to participate in the decisions about their care. Do they want to do that? Don't they want to do that? They always have the right to refuse. Now, you need to communicate. If you're there out to walk the patient and they're refusing to walk, communicate that with your supervisor or your agency. However, they have that right. But keep in mind, the more the client can do without your help, the more you're actually promoting their rehabilitation, right? And encouraging clients to do for themselves may take more effort on your part than actually doing it for them. So think about someone that child that you're teaching them to tie their shoes. It might take 3 tries, 4 tries. And yet, if you do it, boom, 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 it's all done. Well, it's the same thing when people have strokes and illnesses. They have to relearn all those things over again. So it's easier and usually quicker for us to do it for them, but that's not the best. That's not the best for the client. So remember, older and younger people have the same basic needs, and one is to keep as much control of their lives as they can and to feel useful. Okay, so this is an important one, activities of daily living, and they write this from the hospital all the way down to when they're getting admitted in an assisted living. What can the person do for themselves in terms of eating, brushing their teeth, transferring, grooming, that's combing hair, doing their nails, toileting, can they get themselves on the toilet and wipe themselves? Can they bathe or shower themselves? Can they transfer from the bed to the wheelchair and back? So we're promoting independence in these areas primarily, and independence is the goal of restorative. Okay, when we're talking about the ADLs and trying to have people be independent, assist only as necessary. Try to break those big tasks into smaller ones, like put your foot in the shoe, now tie your shoe. Encourage the movement and exercise, provide training as needed to help them do those little tasks, help encourage strength and ability, encourage use of assisted devices and adaptive equipment as needed, which is walkers, dressing aids, special eating utensils. So I have some pictures here for adaptive equipment to use for dressing. And one is, you can barely see it, but he's pulling on these clips, the ropes that are attached to his pants to be able to get his pants up. So they start it from the floor. This one is just getting a button shirt on because they don't have that little dexterity of their fingers, so they could button their shirt. Okay, so here's some adaptive equipment for eating. And you could see these look like travel cups, and honestly, if it's you could they could get nicer looking ones than these, but the travel cups, things like that may work just as well. Here's a special bowl. Here's a spoon that's attached onto someone's hand that maybe can't hold it well. Here is we call them clothing protectors because, they do spill if they're shaky and have Parkinson's and they don't want to get dirty. This way, take it off, they're clean after they eat. Of course, they have to want that on. You can't just put it on them. There's dishes where the sides have lips on them. They're a little harder, higher up, so they could put like get things on a spoon with using one hand, special spoons that are, first of all, thick here, built up, so they could hold on easier. And this one's actually curved, so they could get it in their mouth easier. Okay, so activities of daily living. Families and friends are important to support them. And try to encourage visitors and make the visitors feel welcome and involve the significant family and friends with helping, not assisting them with their ADLs or encouraging the person to do their own ADLs. So that has to have the client approval. You don't want people involved. The client doesn't want it, and the facility. But instead of doing everything for them, the clients or the families are working with the clients, so they also promote independence. So some adaptive equipment are sensory aids that you're familiar with, eyeglasses and hearing aids. Mobility aids include wheelchairs, walkers, canes, and crutches. Some adaptive equipment is prosthesis. It's an artificial substitute for missing body part, like an arm, leg. And then some are more for constructive, like a breast. Um, Prosthetic eye is more for looks, but dentures, teeth, they're prosthesis. So Always encourage independence with emphasis on the abilities, not their disabilities. What can they do, not what can they not do. It's great if we know the correct way to use the device, so always ask your agency, ask the supervisors, and you could Google things, but you still have to ask the agency. If you never used a device before, you need to tell them that. Observe whether the client uses it correctly. And even if you're not familiar with it, you could see if it looks right. Don't let anyone use a defective device. So if you see something's wrong with that device, then don't let them use it. And then check the client for physical problems because sometimes they're using something and it starts to rub, so they start to get sores. Keep clients within keep the equipment within easy reach. And one thing we can do is keep it properly cleaned. Another thing we can do is mark the client's name on the items. So you want to put it in an inconspicuous place, a place that you can't really see it, other people can't. But I'm telling you, there's going to be other people with wheelchairs, and those foot pedals come off, and then they can't figure out whose foot pedal is whose. So if we write a name on each part, then when we go look for it, we could tell it's theirs, not someone else's. Um, and encourage the clients to take care of their own things. And of course, whatever they're using, observe for any problems. Note if they're having problems or if they're making progress and not progress, and report any observations for problems. So I showed you some pictures, but there's other devices to help get dressed, like zipper pulls. You saw the button hooks. Long-handled shoe horns are great. Sock pullovers that people don't even have to bend down to put their socks on. And then long-handled combs and brushes and things to wash your back. And provide privacy, always provide privacy when they're using these, and encourage independence. Independence, independence. Okay, as far as glasses go for vision, um, another thing we can do is things get lost all the time. Mark their name on the inside of the frame. Make sure they have a case at their nightstand for storing them. And see if people, and you're not going to provide it, but you could ask them to buy the neck straps. So if they are taking their reading glasses off and on, you don't lose them. Um, don't use paper tissues to clean the lenses. That's one thing you can do for them, but use some kind of soft cloth to clean the eyeglasses. Okay, so hearing aids, they don't make them hear everything, all the different sounds. They do make the sounds louder though. So sometimes it makes people, like if there's too much noise, background noise, if there's things going on, like a lot of people talking in a dining room and then you've got the TV on, it just makes everything louder. It doesn't make it necessarily better. It's good for one-on-one though. Hearing aids are expensive, so be cautious when you're handling them. If you're going to clean them, never get them wet, but do it over a table or desk so they don't drop to the ground or if you have to change the batteries. Okay, it's important to keep the hearing aids dry. They're little computers and they can't go in the water, so remove them before they shower. If it gets wet, try to dry them off immediately. Don't use any heat, just try to dry them off. Keep them clean with a soft cloth. Never use water, alcohol, or cleaning solvents. Um, you just use a soft cloth, and then there's these wiry cleaning agents to get the earwax out, but it's a cleaning kit. Um, what we will do, they use batteries and batteries get expensive. So turn off the hearing aid when not in use if there's an on off. If there's not, when they go to bed, open it up. So you just open it up and then the battery just it can't work. Um, And if they're not going to use the hearing aid for over 24 hours, actually take out the battery. But they're tiny little batteries, so if we just open it up, then the battery's not connected, and that's easier. Make sure the battery is working before it goes in the ear. And let's pretend I don't have a hearing aid, but this is the hearing aid. What you would do is close it up. Let's say that's the battery. Battery's in, it's closed up. Put your hand over it like this, and it should go, ooh. That's the feedback that it gets from being in a wind tunnel. And if you ever hear that sound when it's in their ear, like you hear, then it just needs to be put in their ear a little better because it's creating a wind tunnel, and there's feedback on it, and it's just not in good enough. Okay, so some problems with the hearing aid. It usually has to do with the battery being faulty and they need a new battery. However, if it's not working and when you replace it, then you need to contact someone to get that fixed. Okay, mobility aids. They help increase independence and decrease complications from being inactive. So that could be like walkers and canes. It has to be the right size for the person, and the client has to know how to use it correctly. And they should be taught by that rehab team. Okay, so one is wheelchairs. Um, the person has to be properly placed in it with their in a 90-degree angle against the back of the wheelchair, and make sure that there's no loose parts, missing parts. The brakes, make sure the brakes work, and keep the chair clean so we can wipe it down. And be sure that it's adjusted right for the person. So I wanted to show you some wheelchairs because I want you to know that almost all the wheelchairs, the arms come off. And a lot of times that could help us if we're transferring like someone from the wheelchair to the bed. And it depends on the situation. Sometimes we want the arms on and sometimes we want one off. And as you could see here, someone else in a wheelchair and how they could get someone in a van with these different lifts. Okay, another mobility device is going to be the cranes and crutches, and a cane is used for balance. Should be usually carried on the client's strong side. Um, and we're going to watch for worn tips, and I'll show you what that is. And over here, these are the tips we're talking about. So this is a quad cane with uh, four of these tips down here. And this one is a regular cane, but now most of them are coming with this tiny uh, four-piece area that helps keep the cane upright when it's not in use. And here are crutches. We hardly see those on older people. It's just too hard for them to use. And here is another assistive device. They call this a couch cane, but to get somebody up out of the couch, and then probably they would go on to use a walker. So let me show you some walkers here. This is the most common in skilled nursing or in rehab areas, and it's called a front wheel walker, two wheels on the front. The back just have gliders, so it glides along. These fold up really small, so they're easy to store. Someone in assisted living who bought their own is probably using something like this. These have brakes up here, and they're kind of nice because they could store things in here, and they could even turn around and sit on it if they need to rest and they're out somewhere. Um, Walkers are ordered by a doctor or physical therapist usually for just poor balance or weakness. And I showed you the front wheel walker, which is this one, the gliding walker. Standard walkers are the same except there's no wheels on them. And then there's also, which is not as common, a reciprocal walker where it just moves a little bit from side to side. I haven't even seen those, though. It's in your book. And then they have these new upright walkers out. And I think because the old-fashioned walker, people do get hunched over. So I'm curious to see more people are buying these where it makes them stand upright so they don't get that hunched over body form. And then this is another type of walker. It's just very stable, but it does fold up to fit in a car. Okay, walkers are by far the most common that I have seen used, and they need to be the correct size. So most of them are adjustable. That you could, all of them I've seen are adjustable. All the pictures that we saw are adjustable. So they have to be the right height. If someone is unsteady and they're using the walker, we could still use a gait belt. That's the belt that goes around their waist to hold on to them as they're trying to learn how to use that walker again. Okay, so now we're going to talk about range of motion exercises, ROM. And we want to encourage activities and exercises to prevent one thing we want to prevent is contractures. And contractures is caused by shortening of the tendons and ligaments. So those are the cord-like things that touch the muscle, the bone. And so if they shorten up, then we get a flexation of this. If they shorten the hands, they get flexed. If they shorten them in the knees, they get bent, right? And what also happens is atrophy or wasting away of muscles, and then they can't move the joint. And this can develop pretty quickly. Okay, so there's different kind of every joint can contracture. So here's a list of them. Um, and we'll look at some pictures here. So a hand contracture, this would be an elbow contracture, and here we actually have a splint on it to try to keep it from contracting more. And it's from disuse. This is a really bad contracture, and those knees will not unbend. And here's a contracture that's formed here. And it's really, we want to prevent. So when we're helping with these range of motion exercises, it's to prevent the complications of immobility. And these are going to come up again and again if you stay in healthcare. So you're preventing muscle atrophy. And atrophy is wasting away of the muscle. And then a contracture with the joints that can't move fully. So once they're contracted, they can't extend again. It's usually flexation. Pneumonia, people that are immobile, not moving around, have higher incidence of pneumonia, higher incidence of constipation, swelling or edema. Edema is swelling. Pressure ulcers, those are bed sores, breakdown of the skin. Urinary problems, UTIs, bladder infections. If they're not moving around, it causes the bones to get brittle, osteoporosis. And if we're not moving around, it causes little blood clots to form in our veins, especially in our legs, called deep vein thrombosis. Okay, so range of motion, ROM exercises involves moving each joint and muscle through the full range of motion. So for the arm, it's going to be like this. And I'll show you some more afterwards. Helps to decrease the mobility, increase the mobility of joints, prevents contractures, right? The stiffening of a joint that can't move again, and atrophy, the wasting away of muscle. Um, and sometimes the clients can do those like in an exercise class, and or we're actually doing it for them. And so their plan of care or care plan will specify what has to be done. Okay, I'm going to show you some range of motion. So this one we could always do, and this is what I like to teach families to do, if allowed, to point, point, and flex, because this prevents that deep vein thrombosis. And if you do this, and I'd like you to do this, point this towards your nose, you're going to feel it in your calf and point. And this, by the way, if you don't do this, people from laying in bed get this contracture, which is called foot drop. Well, if that means that then they can never straighten their feet out. They're not going to be able to walk. right? So point and flex. Okay. And then there's other exercises. So for the arm, we could do extend. Actually, this is flexion of the shoulder and extension, but um, up and down and out. And you could do this while someone's laying in the bed, and you might have to do it for them. Um, excuse me. Okay, another one would be doing this. That's rotating the shoulder. Um, exercising the knee. So just up and down, and that's so range of motion is always putting the joint, this is the knee joint, through full range of motion. Could be the head. And we'll see a lot of people end up being like this, or laying in the bed and pillows behind their bed. They can't straighten their head out. Now I'm going to show you if I was going to assist a client with range of motion of their knee and they couldn't do it themselves, this would be passive range of motion, meaning I'm going to put my hand under the ankle and under the knee. I'm going to say to the client, if you have any pain, let me know because I will stop. And I'll go 1, 2, 3. And we usually do it 8 to 10 times per side. And if I would do range of motion of that ankle, point and flex, point and flex. Again, 8 to 10. Always supporting the joint, telling the person to stop if they have pain. Okay, always you should perform range of motion only if it's directed or if it's on the plan of care, right, by licensed staff or plan of care. Always stop if there's pain, and if someone looks like they're having pain, even stop. Um, and always report it if their joint looks red or swollen. Don't do the range of motion unless they definitely say yes, we're doing that, because once in a while they're things will be done even if it's swollen. And then like those point and flex exercises, I love family to do that. Point and flex of the foot, of the ankle. It's easy. They feel like they're doing something. They could do a foot massage at the same time, and it's good for the patient or client. Okay, again, you're going to do the range of motion exercises through the full range of motion of that joint. Um, so there are abbreviations, and you could always Google these and look them up. Just say medical abbreviations, but it there are for all the extremities, upper extremities, lower extremities, right upper extremity, left lower extremity. So remember, you could Google these as you're going on in healthcare. And we usually just say range of motion, but if the person can't do it themselves, it's called really PROM, passive range of motion, that just like I was doing on the mannequin. An active range of motion is that the patient is maybe following you and doing exercises. Um, and then the in between where they're able to assist somewhat, but you're getting it through the full range of motion. There are also other names at this point, you don't need to know them, that how you're doing things like abducting the arm would be taking the arm away from mid body, just like if you abduct a child, they're taken away. Adduct is when we bring things close together, like we're adding together. Extension, flexion, hyperextension would be like trying to get it even more straight than it usually goes. And then the dorsal flexion is for the feet. Okay, and that's dor, dorsal, plantar flexion and dorsal flexion. Um, but again, there's names for these, but right now you can look them up when you need to. They're not on any test. And that is it for chapter 13, restorative care.